Good morning. My name is Alan Weil. I'm the editor-in-chief of Health Affairs, the leading journal at the intersection of healthcare and health policy. We're really pleased to have you joining us today for the release of the September issue, which is Advancing Global Health Policy. It's an auspicious time for the articles in the journal and the discussion that we are going to have today as global issues are increasing on the domestic attention scene, as well as of great importance, of course, around the world. We have a really terrific collection of papers in the journal that touch on a broad range of issues that should be of interest to readers around the globe, as well as readers in the US interested in learning from what's happening in the rest of the world. We have an exciting program today as various authors and presenters will give you the highlights of the materials in the journal, as well as, of course, there are additional articles that will not be covered at the briefing today. As we begin, I want to acknowledge that this theme issue was supported by the Qatar Foundation, the World Innovation Summit for Health, Hamad Medical Corporation, Imperial College of London, and the Commonwealth Fund. And without the support of those organizations, we would not have been able to release this very substantive issue. We're going to have our first session in a slightly different format than we sometimes have at these briefings if you've been to others. We're going to have a conversation with two thought leaders in the topics that we're covering in the issue today. And so as soon as I finish these formal remarks, I will move about 4 feet over and try to provoke more of a conversational style so that we can go beyond the text of the articles. We will hear from Dr. Mark McClellan, who is the Director of Healthcare Innovation and Value Initiative at the Brookings Institution, and he is the author of one of the papers the lead author of one of the papers in the journal called Accountable Care Around the World, a framework to guide reform strategies and to achieve progress. We will also hear from Professor Lord Ara Darzi, who's the Executive Chair of the World Innovation Summit for Health, which is a program of the Qatar Foundation, and he's the director of the Center for Health Policy at the Institute of Global Health Innovation at Imperial College in London. Both of these gentlemen have biographies that, if I read them, would take our entire morning. So let's move, instead of doing that, into the conversation that we had intended to kick us off. And I do, just so you're aware, Mark has to leave a couple of minutes early, so when he gets up, it's not because of anything any of us said. So I will now put my moderator hat on and begin the conversation by noting that many of the papers that are in the journal that we're releasing today have their origins at the World Innovation Summit for Health that was held in February of this year. Professor Darzi, can you tell us a little about the summit, its origins, its goals, just to get us all to understand the origins of the work?
Well, thank you, and could I congratulate you too, actually, for getting these wonderful papers into this global edition. It's a great privilege to be working with you and also go through the wonderful peer review and the editorial changes you've made. I'll tell you the little story how it happened first. I think some of you may or may not know, I'm also a clinician, but also at some stage in my life, I was a health minister. So I'm a failed politician. And one of the unique, the things that struck me at the time when I was a health minister is the lack of evidence-based policy making. You know, the number of policies that came through on the hoof because a politician happened to be in their constituency and came across an idea, and the idea turned into a ministerial health policy. And the person who really recognized that gap and that deficit is someone I've admired for many years, and that is Her Highness Sheikh Mosa. And that was a discussion we had in the president of the previous president of Qatar Foundation, who is with us, Dr. Saud. And so this idea really, could we have a forum or a summit that actually will look the evidence base out there and come up with, the principle of future policy making, certainly in the emerging economies, but also in many of the developing world. And that's really how it all started. And it was after the generous contribution of Qatar Foundation. We've had it's the second, actually. We had a taster meeting in London during the Olympics, which was called the Global Health Policy Summit. And then the first formal launch of the summit was last year in Doha. And the formula of it is, how do you bring the government political policy makers with the private sector, which is quite important because most discussions around policy tends to happen without the private sector's involvement and industry. And finally, the robustness of academic contribution to this. And that's been, if you like, the formula and the mixture that we bring together around last year, about 8 themes, and one of which we were absolutely privileged to have Mark lead on in accountable care. And the challenge that we tend to put to the chairs and their very distinguished forum members is, what are the evidence-based innovations out there that are making a difference? And the forum output then is these different interventions. And what's unique about healthcare, as we know, unlike any other sector, is the rate of diffusion and the dissemination is always behind any other sector, whether it's the financial sector, or whether it's the entertainment, or retail, or whatever. And so the aspiration of WISH is to bring the thought leaders, the real policymakers, and also the clinicians, the frontline staff who are delivering innovation, and present them with these outputs, and then see whether that will accelerate the uptake and diffusion, which is in many ways the aspiration, as part of the mission of Qatar Foundation, as the president reminded me of yesterday. And I think what's pleasing for me as a clinician, academic, and also I'm a parliamentarian, is what we have here is the outputs of WISH had survived the peer-reviewed due diligence of health affairs. And we see that as a wonderful achievement. So thank you again for having me.
That's wonderful, and thank you for your kind words about the process. Not everyone is, while they're going through it, they're not always so enthusiastic. But we do appreciate the sense that at the end of it, the quality is one that everyone can feel good about. I was not on board at the time of the summit, but I heard from a number of people report back that you gave quite the summary at the summit. That probably there isn't time for the entirety of it this morning, but your focus on, as you just said, accelerating the learning process, and particularly this notion that industrialized countries have a great deal to learn from lower and middle income countries, something that we don't maybe attend to quite as much in the US as we ought. What are some of the primary opportunities for global learning that you took away from the summit?
Well, you will see from the papers related to WISH that some of the best ideas, which are really making the highest impact, are very simple. They don't cost huge sums of money. They're mostly process innovation or business model innovations, or some may have even described frugal innovations that are really, really nurturing in the southern and eastern hemisphere. And there's a lot to learn from that. And the examples are throughout the paper. I mean, mental health will be a wonderful example to look at. The idea that many of the emerging economies or the developing world will have healthcare providers with the skills of cognitive behavioral therapy is impossible. Nearly impossible. So their solution to this is their access through mobile telephony and the ability to use different technologies and apps. And I think there are 2 papers in this edition that looks at the wonderful innovations that are happening in some parts of the world that we can learn from. I think there's another angle to this, which I always say. I've worked in the NHS for a long time. I've probably have made more air miles by telling the world all the mistakes we've made in the NHS. And so we have a lot to actually tell many of the emerging economies in the developing world, all the mistakes we've made in the creation of our systems. Because there is a tendency, certainly in the emerging economies, the wealthier one per GDP, just to copy what we've done in terms of the healthcare system. And that's probably the last thing they need to do, because they're copying something that is broken or needs fixing. So I think it's a two-way communication, and that did and does come up throughout the period in which these forum outputs are put together. I should make a reference to it. It starts about 6 to 8 months before, through with the chair. And then the output is obviously presented at the summit. And then there's a very, very rich dialogue between the different members of that plenary session that we have. And it's interesting to see the leadership of many of these countries in the developing world and the emerging economies really interacting, and the co-production and co-learning that could result from these. And that's the unique, if you like, USP of this, which is very, very different than all sorts of other meetings that I've attended with a global health remit.
Great. We'll follow up on that a little more as we go on with the discussion, but I want to bring Dr. McClellan in. You have worked on accountable care, and particularly in the US, accountable care organizations, working to conceptualize them and bring them into reality. Your paper in this issue is entitled Accountable Care Around the World, which is something probably many in the US have not thought about so much. So the first part of the paper is a framework and a conceptual approach. Why don't you share with us how you defined a framework that takes us beyond the technical elements of ACOs as we know them in the U.S.
Sure, Alan, and also my thanks to add to Lord Darzi's for the leadership of health affairs on this set of global topics. Health affairs has long been a leading guide for health policy reform in the United States, and it's nice to see the journal becoming increasingly global in its focus, because as Ara mentioned, the challenges really are global as well. In this paper, we developed a globally applicable definition of accountable care and a framework for describing and assessing accountable care reforms to really carry out the goal that Ara described, which is to note what is going on around the world, note that the responses to some of the challenges of demographic change, increasingly personalized and preventive-oriented technologies, rising costs are by no means unique to the United States, and thereby to find a way to share experiences and evidence more effectively, the kind of sharing that took place at the Global Summit last year. Well, it turned out that by using this definition and framework, we were able to identify some insights, a broader range of accountable care reforms going on around the world than I had expected. And one of the things that came out of this discussion is we had the opportunity to participate in the Global Forum in Qatar was that we met many more people who are involved in policy leadership, who are involved in implementing innovative reforms around the world that could adopt the same kind of framework and could share in the experiences that we had. So the definition that we came to as part of that process with an advisory group that included global leaders, people in the United States like Steve Shortell and Glenn Steele from Geisinger, people from India like Gautam Sen, people from Australia like Pradeep Philip, who's leading some innovative reforms in the province of Victoria. We came up with a definition, which is a system in which a group of providers are held jointly accountable for achieving a set of outcomes for a prospectively defined population over a period of time and for an agreed cost. That's a lot of words, but what it really means is a shift in focus, as we said in the paper, from an emphasis on paying the suppliers of healthcare, the doctors, the hospitals, the post-acute care providers, the long-term service and support providers, to a focus on demand, the demand side, patients and what patients needed. And this is, in different forms around the world, really a shift from paying for services or setting budgets for silos of care to paying for what you'd really like to see patients achieve. Better quality care, better results, lower overall costs, the kinds of triple aim features that have resonated well around the world, but that have proven quite difficult for many countries to achieve. And then in applying this definition, we were able to look through a number of different reforms being implemented around the world to find some key steps in effective accountable care implementation. First is starting on a population, not starting on a payment system, not starting on a particular group of providers, but a population for which providers would be jointly accountable for achieving better results. Second, also with a clinical focus, and many of the people who are involved in this effort started, like Ara did, from a clinical background, is identifying the outcomes and the opportunities for improvements in care for those populations. And that's a very practical look, including a look at some of the good, innovative ideas that historically haven't gotten a lot of support. Ara mentioned the potential for telemedicine, for smartphone or even just cell phone services to support greater access to basic mental health services, something that many developing countries are leading the way in applying. Well, that's an idea that also has implications for developed countries, but telemedicine has not been a traditional part of many of the payment systems and fee-for-service payments or payment silos that have marked some of the historical policies for payment in developed countries as well. A third component then is metrics and learning, actually developing measures from available data and making incremental improvements in available data to track ways of noting how you're doing and whether you're improving in those population outcomes, using the kinds of innovations in care that can really matter. And that often means starting with some limited data. Many systems have data when preventable admissions occur, say. Many systems are starting to develop data on patient experience with care. So that's a third key element. And then that brings me to the fourth element, which is payments and incentives. This is, in the end, about changing payment rules, about changing regulations to move from a supply to a demand or patient-focused approach to care. But there are a lot of ways to do that. In the United States, this has mainly been in the form of moving from fee-for-service payments to a second payment track that's based on paying more when patients, not when patients get more services, but when they have better results and lower overall costs, not higher overall costs. In other countries that have started out from more socialized or national health system, it often means moving from payment silos where different providers get their own global payment for their silo of services to payment systems that support better coordination of care across the silos and recognize that more spending in some areas, say for telemedicine, may reduce spending in other areas, say for physician visits or hospitalization. So those are the kinds of changes in payment reforms that were key in all of the case examples that we looked at. And that showed that, in fact, it often takes an incremental process to move from where the systems began towards more of a focus on patients and outcomes with improvements in data, improvements in metrics, improvements in providers feeling more comfortable with taking on this new kind of accountability over time. And then that's the fifth component, which is actually watching the results and looking at the coordinated delivery and improvements in care. Are changes in healthcare delivery actually occurring that are leading to those improvements in outcomes and thereby creating kind of a virtuous cycle for identifying and acting on opportunities to improve care and then building on the redirection of resources, the investments that providers are making in working together or delivering care in new ways to take still further steps. So we're able to apply that framework in a number of case examples around the world. Our paper published in Health Affairs focuses on 2 examples, one in Spain, one in Singapore, which really drive home the point that the United States is not alone, not only not alone in implementing accountable care reforms, but in many ways could learn from steps towards implementing accountable care that in some ways are more advanced than what we're doing here in the U.S.
Well, I can't help but then follow up and say, what can we learn if we know that we're trying to move this agenda forward in the United States? There are provisions in the Affordable Care Act. There's activity going on in the private sector around accountable care models. So you have a report from the rest of the world. You just said some of them are ahead of us. What can we take from that?
Well, let me just, Alan, just start with the 2 cases that we focused on in the paper in Health Affairs today. Both of these, Ribera Salud, which is a public-private partnership that provides care in Valencia, Spain, and Singapore, which implemented some accountable care reforms focusing on the frail elderly. For many of you who know the Singapore system, this is one that relies a lot on personal savings and providers delivering care that individual patients can choose. So both of these provided examples of how changes in public policies could work more effectively with private sector healthcare delivery around the goal of better care and lower costs for patients. In Ribera Salud, this was a model for how providers in Valencia and the Valencia region, including small medical practice groups, could work together with a supporting management team to take on much greater accountability for population health costs while tracking and improving population health outcomes. So in that program, they've moved well beyond what many accountable care organizations in the U.S. have done, and they have a substantially large component of their payment that is tied to basically capitation with an emphasis on tracking population outcomes and only renewing the contracts if goals in terms of health, quality of care, and overall costs are met. Ribera Salud has been able to do this, working with a number of small provider organizations around the region, and has done it at costs that are in many cases 25% below what the traditional non-coordinated care providers have been able to achieve. And they've also achieved some very important improvements in outcomes for patients, like shorter waiting times, lower readmission rates. So it's a model that extends well beyond what U.S. providers in many cases have been able to achieve, and we have some more details in our case example about how they accomplish that. Singapore is a good example of taking a concept that in the U.S. has been applied mainly on the acute healthcare side in terms of accountable care and extending it into long-term services and support, palliative care, the other types of healthcare services that frankly can have a bigger impact on health outcomes and acute healthcare costs than many interventions, many clinical interventions just focused on the acute side. So what the Singapore example shows is some good models for integrating payments across both acute and long-term service and support and other payments programs for the vulnerable, frail elderly population with a focus on clinical measures and patient experience measures that really were important to the patient. So not just whether or not readmissions went down, but measures of whether or not people were getting care in the setting that they wanted. So if they had a terminal or advanced illness, were they getting care at home? Were they able to die at home if that's what their preference was, and not in a hospital or an intensive care unit? Did their caregivers have a better experience with care, something that doesn't get enough attention in the U.S.? So another good example of taking some of the concepts that do matter here, but perhaps going considerably further in successful ways of integrating them into a patient-focused payment system and accomplishing more in care delivery as a result.
Mark has just described the accountable care, and it's sort of it's an ecosystem, it's a collection of organization and financing. What do you see as the relationship between the move to accountable care and the broader goal of adoption and acceleration of innovation?
Hugely. I mean, I think it's probably not a new technological invention, but it's a business model innovation that is absolutely every healthcare system is crying loudly for. I'll give you my own, what I've learned from that is I've been leading a major review of London's health services, which was commissioned. It's called the London Health Commission, which was commissioned by our mayor, Boris Johnson, which started in December of last year. One of the pieces of work we did, building on the framework that Mark just made a reference to, population health, have the right information, is to make the case for accountable care delivery models, was to segment the population. We have about 7 or 8 million, depends who you ask, whether you include those who may not necessarily be registered as being London citizens, as you have the same problem in Washington, about 7 or 8 million. And if you segment that population into about 5 or 6 groups, in actual fact, we segmented them to 15 groups with 4 age groups. And the ones that is the largest, about 4.5 to 5 million, is what we call the mostly healthy Londoners, which essentially have an interaction with the health service when they are going to get a vaccination, or they may visit the emergency department if they have a sprained ankle or a wrist, or may have their groin hernia fixed. And we spend on that population somewhere around 3.5 to 3.8 billion pounds a year. And then you have another group out of the 15, which might be interesting to talk through, is those with chronic, what we call long-term conditions. We don't call it chronic disease anymore because most of these patients live with their long-term condition, and in some cases more than one. And we have about 1.2 million Londoners who have chronic conditions, long-term conditions that they live with. We are spending somewhere around, I think, 4.2 billion on that group. And you can see the size. I mean, if I had a drawing, I'll show you the differential here. Another group, which was patients with severe and enduring mental health illness. And there's only 72,000 of those in London. And we're spending 1.6 billion pounds. So we did this segmentation. It's a bit like, if you like, what's happening in the era of life sciences is the personalized medicine, is, you know, how do you segment the population based on their phenotypic presentation. Then we looked at beside the cost, then we did a Mori poll to the different groups to see how they rated their care and what are the major gaps in their care. And it's astonishing to see, certainly with all that expenditure in the chronic, you are getting a huge amount of complaints about the fragmentation of care. You know, most patients in that group want to see the same practitioner. They don't want the usual general practice consultation time, which might be reasonable for someone who may have a groin hernia or a vaccination needs, which is about 7-8 minutes, versus someone with chronic, they would like 40 minutes, but they would like to see the same person. They are more interested in co-producing the care plan with their practitioner. In actual fact, a significant number of these patients know, in most instances, more about their illness than the person delivering the care. So they want to be co-producers of that care plan. They're very keen and very interested in preventative measures. How could they be involved, and how do they help reduce their number of readmissions? So the severe enduring mental health illnesses, the care is provided in the wrong setting. They want outreach, outbound care. They don't want to come into a busy emergency department because they've had an acute psychotic attack. That's the worst place they could be in. So again, you can get that in many ways. And how could you look at the interactions between primary care, secondary care? How could you really drive in some areas? I mean, we need to be slightly careful. Accountable care organizations is not the right solution for everyone. You know, there's nothing in health which is one size fits all works. We know that. But if you look at the biggest challenges facing most healthcare systems in the developed world with the aging population and chronic disease, you come to the same conclusion as Mark's paper, which is a wonderful framework in really driving that. Certainly it's going to happen in London, and I think we've seen some early examples of this also in Qatar, in Doha, where you have to remember, WISH is run in Doha, in Qatar, but it has a very new, emerging, maturing healthcare system, which we'll come back to the cancer one. But what's interesting there, which you just wonder whether UK or the US could have coped with this. A very small population, about 15 years ago, I probably will get this wrong, Dr. Saud may correct me, about 500,000. And within 10 years or 15 years, that population has grown to about 2.2, 2.3 million. So imagine coping with that huge, we keep talking about how we cope with the aging population and the baby boomers and all of that. And these guys are coping with a completely different, very diverse population, comes from different backgrounds. And again, they've come to the same conclusion. Accountable care based on the framework that Mark has put together. In actual fact, I think you're visiting in November to see how we get more integration between primary, secondary care and social care. This is not just about health, by the way. It's about your other needs beside healthcare.
Just would add to that, I mean, the nice thing about the leadership in Qatar on this issue is that because the system is growing so rapidly, because the country is making so much investment in healthcare, they have a chance to make some decisions about policies to support integrated care, preventing complications that we really didn't have a chance to do in this country, in a system that grew up much more gradually and that started in much more of a fee-for-service and fragmented environment. And I think that's going to turn around and lead to more examples and more evidence that will be relevant to developed countries that have a lot of investment and a lot of infrastructure that no longer fits well the notion of personalized, prevention-oriented medicine.
Correct. There are many paths we could go down, but I'm drawn back, Ara, at the very outset you talked about the importance of linking government and private sector. And again, in the US, the move to accountable care is definitely driven both out of both of those sectors. There's been a good deal of discussion this morning about organization and patient engagement, but you're also, as you mentioned, you're both clinicians. Can you talk a little bit about the role of clinical leadership, perhaps of clinical education, if we're going to change models or create more patient-oriented, more team-oriented models? Is there global learning to be done in the area of clinical leadership?
Well, I'll start with that. I think beyond leadership, you're going to have an interesting discussion later, because one of the papers is what we call the global diffusion of health innovation, which was a first attempt at this. It's one of these things in life, if you measure something, you can improve it. Although it depends where you are in the academic thinking. Some people say if you start measuring innovation, you stifle innovation. So it depends where you are on that. So this was an attempt, and Greg is here, he's going to talk about this later, was to understand what makes the difference. Why do some systems or some organizations really take up these innovations and drive that through? And there are all sorts of different factors. There are sort of enablers, which we know as a government, you can come up with a strategy, you can come up with the funding for the research or development, or even the translation, not just it's what I call the T3 translation, because you do also need to understand health services research. How do you actually translate a discovery into evidence, which is clinical trials, but then there's a next phase, is we need to understand better how do we translate evidence into clinical practice. That is a big gap. That gap is getting bigger and bigger and bigger. We keep saying we invest in all these discoveries. The gap between what we know and what we do is getting wider and wider and wider. So leadership is one very important component of that, because the other end beside the enablers is what we described it under the heading of cultural dynamics, which is there's the famous saying, culture will always eat a strategy for breakfast. What are the cultural dynamics in an organization? And leadership is an extremely important part of it. Do clinicians and frontline staff have adequate time to reflect and think through, rather than this is the new world we're living in, which is the automated world, which patients keep complaining about, in terms, you're not listening. You know, are clinicians given the adequate space and cover to be innovative in the very litigious societies that we're living in? I'm not talking about an experimentation with a wonderful new drug. I'm talking about, could we look at the way in which that patient pathway is designed? I remember 2006, we did one little piece of work in terms of purely tracking patients, and we didn't pick someone with chronic disease because we would have spent about a week drawing the different lines, but we did it in patients with what I call a planned care. And you know, if you look at the pathway, purely the dotted lines between the movements the patients make between these different organizations, you come to one conclusion: if this was any other business, it will immediately fail. You'll go bust. So back to the cultural dynamics. You know, do clinicians have the space, the support that they need? Are clinicians rewarded for innovation? I mean, I just make the clear distinction between invention and innovation. You know, because I sort of happen to wear two hats. I also work in a university. You know, we're in the business of coming up with new scientific discovery, whether that's a new drug or a new device, whatever it happens to be. And we're very, very good at that. But I'm talking about the uptake of that is actually, how do you translate that? Are we really rewarding those guys? We reward the professors in universities by saying, well, you're going to be a professor now or head of a department because you brought so much money from NIH, because you published so many papers in Nature. Are we doing the same? Are we rewarding the frontline clinician who's really bringing a very simple innovation into clinical practice and making a huge difference from a patient's perspective? Do we have, within those cultural dynamics, again, do we have a system that encourages patients to be co-producer of their care? And what's the evidence of that? And there's plenty of evidence that if you engage the patient, in most cases, the patients actually have many of the answers that is being raised as a result of their whatever surveys you use in capturing that. So some very interesting cultural dynamics which makes one organization different than the other in the same city, let alone in the same globally. And again, word of caution, it's our first attempt, and I think we've more to learn from this. It's interesting, we can actually measure the invention rates of different countries, and the United States is well ahead of anyone, because I think UK comes second. You can measure that by how much money you spend in R&D, what's your number of patents you produce per year, what's the translation of these patents into SMEs, how many of these SMEs are employing people, and the United States is well ahead, and the UK is the second when it comes to citation. But interestingly, if you go and measure the uptake of innovation, okay, US does better than the UK, but we're not the first movers in that. There are new, up-and-coming countries who actually have a much better ability to uptake innovation rather than just their invention abilities.
Mark, I'm aware of limited time. I'd ask you to either talk about clinical leadership or just take Ara's last comment and ask you to reflect on what are the best opportunities for global learning at this point.
Well, sure. Actually, those two are related, so maybe I can combine them together. I would highlight that in all of the case examples that we looked at, clinical and clinician leadership was very important, and it goes to this point that Ara was emphasizing about culture. So a lot of people who in the U.S. have focused on accountable care as really being about, you know, quote unquote, incentivizing doctors and incentivizing health professionals to do the right thing. I think a better way of looking at this, and in the most successful examples that we've seen here in the U.S. and around the world, is one of alignment. So organizations, especially clinically led organizations, start with some professional norms and expectations about why they're there and what is important in their work. And one of the biggest sources of frustration in clinical practice today is the lack of alignment between what brought people into medicine, that is making a difference in the lives of their patients, and what they get paid and supported to do in their day-to-day practice. They don't get paid to spend time with their patient. They don't get paid to develop kind of innovative ways of providing care, like answering emails or being available and supported, having a team to support them on the weekend. So the successful models of accountable care have started not with just a narrow look at how do we set up financial incentives, but rather have started with what really should motivate effective care, the best care at the lowest cost in the organization, and how do we develop payment policies and other regulatory policies to support that. I think this has implications as well for medical education. Here in the U.S. especially, there's very much a tradition of clinicians being dependent on themselves and taking on a lot of responsibility for the areas that they control, but then drawing a line and say, that's not that specialist issue, that's not my problem. I took care of the patient in the hospital. What happens in post-acute care is someone else's issue. So some changes in education to support more team-based care still are difficult in coming here in the U.S. There have been some recommendations along those lines, including from the Institute of Medicine, but I think more attention is needed. And if you look at some of the other key components of our framework, including the ability to develop analytics that reflect what matters to clinicians and especially their patients, that's a different kind of work as well that involves really getting into, as Ara said, in many cases, changes in practice that may be pretty simple, but if you don't pay attention to them, if you don't support them, they don't happen. You get slow, very slow diffusion of effective innovation. And just to take this back to sort of the big picture of implications globally, we unquestionably have a diversity of healthcare system around the world and a diversity of views across nations about the role of government in healthcare, the role of the private sector, the role of personal responsibility. That said, I do see some real areas of convergence, and I think it's driven in part by the fact that so much of medical innovation today, the kind of innovation that the WISH program has highlighted and continues to highlight, is about more personalized care. It's about bringing in insights from the digital economy and other sectors that have had a hard time taking off effectively in healthcare, and that are increasingly making the traditional systems of financing and organizing care, whether you started from a fee-for-service and very pluralistic system as in the U.S., or whether you started from a more siloed but national health system as in the UK, they just don't fit. And especially for the developing countries, the emerging economies that are making big investments now in increasing the capabilities of their healthcare systems, they can't just look to these old models. They have to look at some of the same experiences that we focused on in developed countries, and that kind of convergence means a real opportunity for global learning. This is hard work. Innovation is really hard work. Finding good ways, effective ways to both improve outcomes and lower costs with new approaches to care that sound good on paper, but that often don't work out in practice, it's really hard work. So having an ability to draw on global experiences is more important than ever in getting to effective healthcare reform and better health for the people of the world.
Those are great words, and we'll let you run to your next, I think it's an airplane, but really appreciate you carving out some time. We're going to continue for a moment to just to piggyback as we close up this session, Mark's last words are a great lead into your planning for the 2015 WISH Summit. Yep. You've identified 6 areas that you're going to focus on. Tell us a little about how you choose your focus, what's the focus, and what do you hope to get to keep this agenda moving?
Sure. It's always a challenge when you try to pick 6 or 7 areas in health, considering all the challenges facing us. It's getting the balance right as well. What's of interest to the developed world versus the emerging economies and some of the... So we picked this year, one very important one is communicating complex health messages, which, it depends whatever sector you're in. Governments don't communicate health reform. I mean, I don't have to remind you of that here. One of the reasons your Affordable Care Act was, it was just purely communicative. You know, and it's interesting that, because I've seen that back in the UK as well, where, you know, politicians stand on platforms and be able to engage and, you know, and have, you know, your system is going to save more lives, whatever it happens to be, rather than the technical jargon we ended up talking. So that's one end of the spectrum. But there's also the other end of the spectrum. I mean, one of the big challenges we have, I don't know about the United States at the moment, is the signs of rumors in vaccination. I don't know whether you have that. I mean, we've had a serious issue with that, the uptake of vaccination, because of, you know, some rumor floats around, and how do we understand and how do we neutralize that? So that's a very, very exciting forum, which we have a distinguished academic journalist who's helping us with that, and very, very keen to see the output of that. The other angle this year is around affordability. I mean, that's a global problem now. And so we're looking at the affordability of new cancer drugs. Is there any other ways of looking at the way in which pricing, and, you know, that's why the private sector is important, because we need to work with the industry, the life sciences industry, and find ways and how, and that's where, again, you know, you need to bring in some political willpower to look at the different business models and understand the different challenges facing us. But the affordability also, we have another forum on universal access to healthcare, which is something of huge interest in certainly in Qatar, in China, and India, and all sorts of other places. So there's an interest on that. You probably know about the G8 and their work on dementia. They were very keen to work with us and see whether we can do something around dementia as well in terms of policy. So I think there's a meeting in February here in Washington, which is hosted by the US government. And then after that, we may get some of the outputs of where they are in terms of dementia. So they're, if you like, some tasters of what's ahead. We also have some speakers. We don't spend much time with with speeches. There's a maximum 4 to 5 speakers in 2 days, and then I think the one thing which we haven't mentioned at the summit, if you might be interested, is what we call the innovation showcases. So we're not looking for a major multinational company to have a big display of anything. We're talking about, you know, simple stuff like the E-Ranger ambulance in Africa, which has reduced the MGD for the maternal mortality rates by about 30% by having an ambulance on a motorbike. You know, that simple innovations that exist, they're very, very exciting. So that's a flavor of what's to come.
Terrific. Well, thank you for your insights. This is the end of our first segment. We'll be back in about 10 minutes after a break to start talking about costs and prices. Thank you. We're going to continue the discussion with a series of 3 panels. I do want to note at the outset that we're going to run straight through with each of them after the speakers and the Q&A. We're just going to bring up the next group. So as you need coffee or a break, you'll be on your own. But we wanted to keep the flow of our discussion this morning. Our first panel is on costs and prices. We have 3 papers that are going to be presented on these topics. You'll hear first from David Himmelstein, a professor of public health at City University of New York at Hunter College and a lecturer in medicine at Harvard Medical School, staff physician at Montefiore Medical Center. He's a co-founder of Physicians for a National Health Program, which is a single-payer, long-standing single-payer advocacy organization in the United States. You'll hear then from Sarah Tuffer, a research fellow in pharmaceutical policy and economics at the London School of Hygiene and Tropical Medicine. She's a seminar leader for the Economic Analysis for Health Policy module and project supervisor for the Masters in Public Health Distance Learning Program. And finally, Iain Cockburn, the Richard Shipley Professor in the School of Management at Boston University, where he teaches and conducts research in the areas of business strategy, intellectual property, economics of innovation, and management of high technology companies. So without further ado, I will turn it over to David Himmelstein.
This is a paper with several co-authors from various countries. And we were motivated by limited data from really US and Canada, from others that showed that administrative costs in US hospitals were much higher. The purple is the clinical costs of doing this complex operation, and the yellow is the administrative cost in the two nations. This is an older study. We wanted to look at a range of nations ranging from less market-oriented to more market-oriented healthcare systems. Interestingly, while England has moved towards saying they want patients to be treated as customers, Scotland has devolved and says it wants patients to be treated as the owners of the healthcare system and has moved to a less market-oriented healthcare system. What we did was to obtain detailed official hospital financial data for 8 nations, aligned accounting categories in consultation with local experts and government officials, and we calculated administrative spending in both dollars and as a share of total hospital expenditures. I won't go through this slide in detail. This is one of the sets of the Medicare data. There are about 30 different cost report sheets that each hospital fills out. We analyze these, and this is examples of some of the very limited slice of the data we looked at. We looked at 2 categories of administrative costs, what we called central, that's hospital managers and executives, billing departments, nursing administration, HR departments, and so on. And that in addition to IT and administrative work that's carried out on clinical units. Now, for France and Germany, those clinical administrative costs, so the things like ward secretaries who do clerical work, were not available. So for those nations, we could only calculate central administrative costs. And what we found is that US costs are way out of proportion to those in other nations. So the US is in yellow here. A quarter of total hospital spending goes for administration in our country. The least market-oriented countries, Scotland and Canada on your left, about 12%. And as you see, the other nations arrayed in between. Netherlands has recently been moving towards the most market-oriented of the European systems. In dollar figures, US is spending about $667 per person in the entire nation on health administration each year. Canada and Scotland about $160. And when we looked at central administrative costs, and there we could get in France and Germany, they are intermediate as well in their market orientation. So if one sort of arrays the costs on the y-axis, so going up and down, and the extent of market orientation of the healthcare system going from left to right, the least market-oriented systems, those with the least complex billing and least entrepreneurial incentives, have the lowest administrative costs, and those with the most market incentives and most entrepreneurial incentives by far the highest. Within the US, some other interesting data that for-profit hospitals have significantly higher administrative costs than their nonprofit counterparts. And trends in the US are also notable. So back in 2000, we spent a little bit less than 1% of our gross domestic product on hospital administration. And by 2011, we were at 1.43% of our total gross domestic product administering our hospitals. In England, one sees similar trends as they move to market-oriented reform, starting with the Thatcher administration. Their administrative personnel, charted here, trended sharply upwards. And one really sees the opposite trend in both Canada and Scotland. Canada's administrative costs were actually lower in 2011 than they were in 1999. And just to put this in a bit of context, it's not just hospitals that are expensive to administer in the US. This is some data that's not in our article for physicians' office and billing costs. in U.S. versus Canada, the insurance overhead in the two nations, and total administrative costs, where we spend about $2,300 per person more than they do in Canada administering our healthcare system. The bottom line, market-oriented reforms sharply increase administrative costs, and a single payer reform in the U.S. could achieve savings of about $158 billion annually on hospital administration alone. We would estimate about $400 billion in total administrative savings that could be achieved by moving to a simplified universal healthcare system. And trying to think of an appropriate quote to summarize this, Charles Dickens, in his tale of poor travelers who were relegated to the outbuildings when the hostel that was built for them was fully occupied by its charitable administrators. He said in his Christmas stories, I found, too, that about a 30th part of the annual revenue is now expended on the purposes commemorated in the inscription above the door, the rest being handsomely laid out in chancery law expenses, collectorship, receivership, poundage, and other appendages of management, highly complementary to the importance of the poor travelers. We are moving towards that in our hospital system. Thanks very much.
Good morning, everyone. The paper that I'm discussing today examined an intervention that subsidized malaria treatment in 7 African countries. Just a bit of background on the treatment for malaria for those of you that don't operate in or work in this area on a day-to-day basis. So the current recommended first-line treatment for malaria are known as artemisinin-based combination therapies. In most malaria endemic countries, they're officially provided free of charge in the public sector. However, use of ACTs remains low, and some of the reasons for this include long distance to facilities, public sector stockouts, and treatment seeking in the private for-profit sector. And in the private for-profit sector, a different class of malaria medicines, non-artemisinin therapies, are widely and cheaply available. And some of the implications of low ACT use include increased mortality if someone takes a treatment where there's drug resistance, so that can lead to treatment failure, as well as the continued spread of drug resistance for monotherapies. So there have been a number of initiatives that have sought to improve treatment outcomes in the private sector, and the intervention that I'm speaking about today is one such example. It's called the Affordable Medicines Facility for Malaria, or the AMFM. And the idea behind AMFM was the observation that many patients are able and willing to pay for these cheaper medicines, the non-artemisinin therapies, and if quality-assured ACTs could enter the distribution chain at the same price as these older medicines, then by the time they reach patients, they would be similar prices, and patients would choose the quality-assured ACTs over the older class of medicines. So AMFM had 3 components. The first, the Global Fund negotiated with the 6 manufacturers of quality-assured ACTs. The largest component of the intervention was a co-payment. So the Global Fund paid the manufacturers anywhere from 80% to 99% of the ex-manufacturer price, and then private sector importers paid the remaining 1 to 20%. And then the third component was a set of supporting interventions that were intended to facilitate program implementation. So this included things like recommended retail prices, mass communication campaigns, and training. So AMFM was implemented as 8 national scale pilots in 7 countries. So 3 of those countries were in West Africa, Ghana, Nigeria, and Niger. Countries in East Africa, so we had Uganda, Tanzania, and Kenya. And Tanzania is actually considered as 2 separate pilots. There's a mainland pilot and Zanzibar, because Zanzibar has its own Ministry of Health and has its own grant arrangements with the Global Fund. And then the third pilot, or the last pilot, in Madagascar. So first, it's helpful to look at the prices of anti-malarial treatments in these countries. So this compares the price of quality-assured ACTs before and after the intervention, so shown by the green and the green outline bars, and the price of non-artemisinin therapies, which are the purple-filled bars before the intervention and the bars with the purple outlines after the intervention. And what we see is prior to the intervention, in 7 of the 8 pilots, quality-assured ACTs were considerably more expensive than the non-artemisinin therapies. Madagascar was an exception here because there is a pre-existing national subsidy program for quality-assured ACTs. So after that are in between our baseline and end-line survey, we found substantial reductions in the prices of quality-assured ACTs in 6 of the 8 pilots. So that's everywhere except for Madagascar and Uganda. And these price falls were quite substantial. So in all of the 6 pilots with big price decreases, end-line prices were less than 50% of the baseline level. And in 3 of those pilots, they were less than a quarter of the baseline level. In order to get an understanding of whether the prices of quality-assured ACTs could have fallen further, we compared the end-line quacked prices, so the quality-assured ACTs, with the recommended retail prices, which were implemented in 7 of the 8 pilots. And what we see is any country that lands on the dotted line means that end-line prices were equal to the recommended retail levels. And what we found was the 25th percentile never fell below the recommended retail price in any of the pilots, which gives some indication that the recommended prices were acting as price floors. What we also found is that there were 3 countries, Uganda, Nigeria, and Niger, which are above that dotted line. And in those countries, prices were considerably higher than the recommended retail levels. And these were actually countries where there were considerable problems related to the implementation of the mass communication campaigns, which again provides some evidence that the promotion of RRPs play an important role in leading to lower prices in a supranational subsidy like AMFM. And so we also looked at the absolute markups that were placed by retailers on the quality-assured ACTs and the non-artemisinin therapies. And the patterns we see here are very similar to what we saw for pricing. So we see substantial falls in absolute retail markups in 6 of the 8 pilots. And we only see 2 countries where the retail markups on the quality-assured ACTs were equal to those on the non-artemisinin therapies, and that was in Kenya and Tanzania. And so we asked a question in this paper whether the substantial falls in quality-assured ACT prices were sufficient, or whether they could have fallen further. And so we do this by looking at a few different things. So first, we looked at the prices in relation to the recommended retail prices. These were set in each country through consultation prices, and the prices should reflect both the costs of distributing medicines in that country, and were supposed to allow for reasonable markups at each level of the distribution chain. And what we found here, again, is that the RRPs were acting as a price floor. So we need to be careful in setting their level and ensuring that they're promoted adequately. So I haven't presented this in the results slides, but we also looked at relative retail markups, so that's the percentage markups. And what we found is everywhere but Uganda and Zanzibar, they were within the range of regulated retail markups in all of the study countries. And then we also looked again at the relationship between retail markups and prices for the quality-assured ACTs and the non-artemisinin therapies, which are the drugs that quality-assured ACTs are supposed to compete with. And what we found here was that everywhere but Uganda and Tanzania, there is evidence that the prices could have been lower. They were not yet competitive with those medicines. But one of the things that we found was that in these other countries, it's the wholesale prices that the retailers face are a limiting factor on lowering prices. So in most of the countries other than Tanzania and Kenya, we found that the quality-assured ACTs were actually arriving at outlets at a price that were higher than the non-artemisinin therapies. So there is no way that without something happening higher up in the distribution chain, that we could expect retail prices to be competitive with the non-artemisinin therapies. Thank you.
Good morning. My name's Iain Cockburn. I'm going to present some work which is joint with my longtime collaborator, Ernie Berndt at MIT. Here we go. I think one of the shocking failures, I've come to describe it to myself as a shocking failure of the global system of intellectual property rights as it impacts the pharmaceutical industry, is the very slow and very low rates of diffusion of new drugs into, outside the wealthiest countries in the world. Something is, in my view, kind of badly broken and really needs to be fixed. Specifically, what I want to talk to you about this morning is the work that we've been doing, tracking the uptake of new drugs around the world. And let me preface that by saying this is not the, probably equally serious problem of lack of investment in so-called neglected diseases. These are drugs that have already been invented, already been tested, already been introduced to the market. The reason I find this a shocking failure, therefore, is that having done all of that work, there really is no good reason why people living in lower income or emerging countries are not getting access to the benefits of this innovation. To move to the punchline, I think that our interest here is in what this has to do with policy choices around, for example, patents and intellectual property. And one of the things I think that we see looking around the world is that many lower income countries are focused on the idea of lowering prices for drugs. And one of the tools they try to use to accomplish this is weak or difficult to enforce patent rights. Now, probably many people in this room have at this point tired of debates around the TRIPS agreement and very emotional discussion about this. I think one of the things we would like to stress is, look, before you can start having a discussion about affordability and start worrying about the sky is falling kinds of discussions that we had in the run-up to signing the TRIPS agreement and its later implementation, that somehow the prices of drugs were going to skyrocket and people in poorer countries were going to be severely hurt by this. Before we can have this discussion about affordability, a drug has to be available. And you can't start worrying about the price if you can't get hold of the thing in the first place. So what we see here, I think, is an interlinkage between the affordability and availability issues in that drugs which attempt to get lower prices, either through weak or hard to enforce patents or through price regulation, are also ones which are paying, in our view, a significant cost in terms of reduced access to new drugs. The problem with these policy measures which attempt to push down the price of drugs is that they limit commercial incentives to bring new drugs to market. What you see in countries which have weaker intellectual property rights or stronger price regulation is that many new drugs either take a very long time to become commercially widely available in these countries or may never be launched at all. I'll just show you a few of the charts and tables in the paper to try and drive this idea home. The first of these is, in some sense, tells the whole story. What we did was we looked at 184 drugs first launched in the United States in the previous decade, 2000 through 2010. What this chart shows on the right-hand side is the fraction of drugs which are available in the marketplace. The x-axis is the amount of time that has elapsed. So you can see in the US and Germany that the great majority of these drugs become available within a year or so. The red line is India, and this is not to pick on India, but India is a country where a lot of the debate around these issues seems to be very, very lively. You can see for India there that in contrast to the US or Germany, it's going to be taking 5 or 6 or 7 years for even half of these new drugs to appear, and even after 10 years, there's still 20% are missing. That is, in my view, a shocking problem. A couple more facts you might find helpful to think about. Drilling down a little bit, which drugs don't get to India or take a long time to get to India? The answer is the small ones. So we use a fairly crude measure here, which is we just rank these drugs by their first full year of sales in the United States. That gives you a sense of the size of the market in economic terms. You can see that the small blockbusters will get to India. So Indians get access to lovastatin reasonably quickly. What Indians don't seem to get access to are these drugs so anything you think of as being a targeted therapy or serving a smaller population, these are the ones which are going to take a long time to get there. Look at the disease categories down there. I think the bottom line from looking at this is if you are somebody in India who has a relatively infrequently occurring cancer and hoping to get access to a targeted therapy which might help you out with this, you're probably going to unfortunately die before it gets there. I think that's a real problem. Why is it the case? Why does it take so long for these drugs to get to India, if indeed they get there at all? And the answer, I think, is very plain from these figures. The problem is that most new drugs arrive in India either genericized or very quickly become genericized. This reflects features of India's patent law, difficulties that the multinational companies have had in enforcing their patents in India. What that means in an economic sense is that nobody steps up and incurs the fixed cost of launching a drug into one of these markets. That's kind of small in economic terms, that the anticipated stream of profits from launching a new drug is going to turn out surprisingly close to the fixed costs of entering the market. Somebody has to pay to get through regulators, develop the market, educate prescribers, and without some kind of intellectual property protection or some kind of friction in the marketplace to protect the first entrant, we're going to end up in a situation where nobody steps up. I've focused on India here. This is one paper in a larger project I've been working on. The situation is indeed worse outside India. And I think we're stuck with this policy problem. We've tried through the TRIPS agreement to impose the kind of patent system we're familiar with in richer countries. That seems to be politically unworkable in many of these emerging market environments. And the onus is put upon us, therefore, to come up with an alternative which gives a commercial incentive for the private sector to spread more widely the benefits associated with new drugs.
Thank you. I'm going to kick off with a few questions, and then we'll have a microphone to bring around to those of you who have questions in the room. David, can I just start with you? You focused on the market elements as sort of your correlation with higher administrative costs. When we went through a debate in this country about the minimum loss ratio requirements in the Affordable Care Act for insurance companies, there was a lot of discussion about what is administrative and what isn't, and particularly there are other elements like legal compliance and the proliferation of quality metrics and the like. And I just wondered if you could weigh in on the role of different components, and particularly in a global issue, whether you have a sense in the other countries where you examine data, whether the composition within what you consider administration differs across the countries.
Yeah, it's hard to know precisely, but it does look like the vast majority of the difference is actually the billing costs and the games playing costs. So basically, if you have to bill dozens of different insurers and negotiate rates with each of them, that's an enormous cost. I mean, just to give you an example, visiting a friend at a hospital in Toronto a number of years ago, when we looked into his bill, the billing office at what was then Toronto General Hospital, 900-bed tertiary care referral center, full range of services, was 4 people whose job was to send bills to Americans who wandered across the border. And when we got back to Boston and went by the billing office at Mass General where I work, and there were 275 people in the billing department, same size hospital, same range of services. So that's one, but the second is the games playing. So just to give you an example, at Cambridge Hospital, where I spent many years, we got the message that our adjusted mortality rate was 40% above expected for Medicare patients. That's an emergency. And the administration's response was to hire a consulting firm, which placed a nurse on each clinical unit to review the charts and find in them documentation that wasn't using the right language to fit the Medicare risk adjustment formula. And would then instruct our interns and residents to change their documentation. Instead of acute kidney failure, write acute renal failure. That would count. Cost $600,000 a quarter for that consulting firm, which did nothing clinically useful, but lowered our adjusted mortality rate from 40% above expected to 1% below expected in 3 months, and raised our Medicare billings by $3 million. So I think it's those entrepreneurial games and the games to meet the so-called regulatory or accountable care targets that actually raise our costs and also give our data the reliability of a tax return.
Sarah, you focused on how the recommended retail prices you observed became effectively a price floor, and that does stand out certainly in the data. The question then of whether lowering those prices would actually, lowering the recommended prices would actually lower the observed prices is a somewhat different question. And so I wonder if you can help us with the chain of logic here. A neoclassical economist would probably say a recommended price is irrelevant. You observed what appears to be a relevance to it. So how do we think about the effects of the recommended retail prices?
So I think there is a few things to consider here. So one of them is, so there's sort of two things. So on one hand, there is some evidence from another intervention that not having a recommended retail price actually could lead to lower retail prices, but only if there is sufficient competition among providers. And in some of the places where some of these drug shops are located, they might be the only drug shop that's there. So we don't have the conditions in some of these markets for the lack of a recommended retail price to lead to lower pricing. So I think that is one of the major issues. I think another thing to bear in mind is really when setting the retail price, the recommended retail prices, is the price of the competitor drugs, so the non-artemisinin therapies, because we know that outlets and distributors are more than willing to sell those drugs with the lower markup. So I think those can provide a good benchmark in setting those prices. So one of the pilots where there was a smaller reduction in prices was Ghana, and what we saw is the price of the subsidized medicines was equal to the RRP. It's just that RRP was set at 3 times the level of the price of the non-artemisinin therapies. So there is an example of a country where they might have been able to lower their RRP and achieved better prices.
Iain, when you show the chart with the U.S., Germany, and India, you can certainly see sort of a moral case that though the curves of those lines should be more similar as a first-order preference for equity. But as your paper talks about, there is this balance between equity and level. And so I guess my question to you would be, should we have as a goal really a uniform global rate of adoption, if you will? Is that going to lead to the not just equity but also the level of innovation that we want, or is some degree of variability in those the curves of those lines both inevitable but actually desirable from the perspective of improving the pipeline of drug creation?
Yes, I think that it may not be the desired outcome and to have all drugs available in all countries on the same timetable. There are many reasons why some drugs might not make it to some countries. For example, the drug may only be useful when combined with complementary healthcare, which is beyond a country's current ability to afford it. Some drugs, just think about something which requires state-of-the-art diagnostic imaging to help with defining a treatment protocol. It's also the case that there is indeed a trade-off. It might well be that the gains from having lower prices on blockbusters outweigh the costs associated with effectively denying treatment for a whole bunch of innovative new therapies to smaller numbers of people, and that might be a policy choice, that a very difficult policy choice, but one which a given country might decide to make for itself. I absolutely agree. That said, I feel like though we might not expect those curves to all, on that diagram, to all overlay each other, I think they should be a lot closer.
Okay. We have time for engagement by those of you in the room. Let's get a microphone over here. Please identify yourself.
Hi, I'm Jeff Stensland from MedPAC, and I had a question for Iain. A little while ago, we had the Minister from Health from Germany in to talk about drug pricing and approval of drugs in Germany and how it moves through the system. And I thought one interesting thing is, at least in recent years, they've had a comparative effectiveness panel. They didn't look at cost, it just looked at, is this clinically effective? And is it more effective than things already in the system? And if it didn't pass the panel, then they weren't going to be able to charge, or at least not be able to charge more. So you could see that is having a higher curve always better? And I'm wondering about what is the different drugs that are missing in the curve. If the different drugs that are missing are higher cost things that seem equally effective, well then maybe it's actually better to be lower on the curve. And I wonder if you had any thoughts on that.
I guess it depends on your view of how good these processes are at winnowing out, relatively high cost and ineffective therapies. My personal view is that I think the marketplace can do a good job in sorting these things out. I think that to the extent that drugs are not, experience very long approval delays, and that's because there's well-founded skepticism about the cost-benefit ratio, well, that's probably good. To the extent that these very long approval delays are driven just by under-resourced or ineffective processes for getting a drug to market, that's bad. To the extent that they're driven by this kind of commercial calculus of the costs of getting through whatever the process might be, right, are too high relative to anticipated benefits given, the likelihood of rapid genericization, I think that's also bad. Your point is well taken. As we continue to work on this, I think we're very interested in, where these barriers are getting into markets come from, and are they sort of well-founded, or they just reflect, under-resourced administrative systems. I do feel personally that, how many drug approval agencies does the world need? Not 194, probably more than one. And there's probably indeed some useful room in a public health sense for taking, health and safety kind of approval for granted. Will a country then, especially if it's a mostly government payer system, decide to go ahead and launch it?
A question here. Oh. We'll get. Go ahead. We'll get her next. Sorry, I meant that order, but we'll catch you next.
Oh, thank you. I'm Evan Lee. I work for Eli Lilly and Company, where I oversee our global health programs. And I did start my professional life as a primary care physician in Cambridge, actually working for Harvard Community Health Plan. So my question is to Dr. Himmelstein regarding some of what we just heard on the first panel about the need to find incentives and the space for innovation among the healthcare delivery system, and that innovation will come at a cost, with what you're saying about the desirability of moving to a single payer system. And I see a potential sort of conflict between a single-payer system which might stifle the need for innovation, which we heard about earlier, and your thesis. So.
No, I think quite the contrary, actually. I think our payment system stifles real clinical innovation in delivery. What we have is we have commercial pressures that, in fact, limit what doctors and nurses and other health workers can do. And I can tell you that at Cambridge, my experience is that the bottom line was very much in contradistinction to what we wanted to do. When we went out and said, let's coordinate care and improve care, we started not from our highest cost patients, but from the clinician's point of view, from our sickest patients. That seemed to us to make the most sense. The problem was that coordinating their care actually tremendously increased their costs because they weren't getting nearly the amount of care that they actually needed. And what our payment system then said to us is, don't do that. That's actually exactly contrary to what the ACO incentives say you ought to be doing. Don't take your sick patients and improve their care if that increases their costs. And there are a raft of other examples of that. In fact, most incentives for doctors and other health workers aren't financial. Financial incentives as a primary care doctor are mainly insulting for me. Don't tell me you'll pay me an extra $5 for that pap smear and that's what's going to make me want to give good care. That's an insult. If I invite you for dinner and I make a particularly good dinner for you, and at the end of it you say, here's $10 because you did such a good job with dinner, that's not what makes me invite you back for a return. And I'd suggest that doing good work is not financially motivated as a doctor. In fact, trying to get people to do good work when no one is looking and no one is paying is what we need to do. And when we offer those kinds of financial incentives, it's quite the reverse. And the Israeli daycare center experience, I guess, is the clearest demonstration. You know, when they started fining parents in a randomized trial for late pickups of their children at the daycare centers, the late pickups went up. Because it became a financial transaction rather than a moral duty to pick up your child on time. And when they abolished those fines, in fact, the late pickups didn't go back down because once you've made it a financial transaction and taken the moral dimension out of that work, then there's no going back. So I think, in fact, we need to take the money out of the caregiving, not put it in these incentive-oriented ways.
Okay. In terms of all physicians and what motivates them, certainly the human and the moral aspect is an important part of what makes you become a physician in the first place. But I think there is, or should be, scope for the financial incentive.
You know, Don Berwick years ago wrote a beautiful essay.
I have a feeling this is not going to advance the evidence too much further. And we have a question here I want to make sure we get in before the break.
Hi, I'm Rena Eichler with Broad Branch Associates, and I work in a number of very low-income countries. And I'm interested, Dr. Himmelstein, in sort of your thoughts about if you start from basically a public system, everybody is a civil servant, essentially. They get their salary whether they show up for work or not, and they don't often. And they are actually not paid very much, so maybe that extra bit of money matters. I mean, what is your view on how should the system evolve? You know, you have a payer, in essence, the Ministry of Finance paying salaries. I mean, what should happen to make these systems effective? And I just want to sort of share for a minute that I do have a bias in that I have seen, and there's evidence that results-based financing or pay-for-performance kind of things really does push and motivate a lot of focus on population health. And then comes the question, who's paying for that? And I think there's a real tension here. It's not quite so black and white, but I'd be interested in your thoughts.
There may well be, of course, differences between developed and developing nations. Within developed nations' healthcare systems, we've had extraordinary disappointment with pay for performance. So the Medicare pay for performance schemes, thus far, the premier demonstration showed no improvement, if anything, a worsening of mortality with the pay for performance. In Britain, there was this early, it's working, and then actually the results now have shown that it's not working. The most recent New England Journal article shows that at 2 years, there is no improvement in hospital mortality. The randomized trials in education, and there's the only place we've had randomized trials, so $150 million we spent on a randomized trial of pay for performance in education in New York City showed, if anything, the outcomes worsened with pay for performance for teachers and schools. And in Memphis, Tennessee, a large-scale trial for mathematics teachers showed worsening of performance of their students with pay for performance. So there may be, in a society where we have, in fact, a highly structured work environment already and largely disciplined health professions, that may be a different circumstance than in countries that's not. I might also point out, Canada is not a civil service country for its healthcare system. In fact, it's a largely privately delivered, but almost entirely publicly funded healthcare system. So that's a quite different setting than you suggest for a civil service.
So I'm going to have to move us into some additional discussion. This was a great panel and kicked us off and gets us into the policy issues. Please join me in thanking this group, and we're going to call our other session. Our next panel is going to discuss 2 papers that relate to the provision of chronic care from a global perspective. We will hear from Bianca Buurman, an assistant professor at the Department of Internal Medicine and Geriatrics at the Academic Medical Center in the Netherlands, and from Julia Adler-Milstein, an assistant professor at the University of Michigan School of Information with a joint appointment in the School of Public Health, Health Management, and Policy. To kick us off, Bianca.
Thank you very much. I would like to talk you through our article published in this month's Health Affairs on transitional care interventions to prevent hospital readmissions for older adults or for adults with chronic illnesses. We conducted a meta-analysis on 26 RCTs, including 13 countries and 8,000 patients. And we had several questions that we wanted to address in this meta-analysis. First of all, we wanted to address what is the overall effect of transitional care on rates of readmissions. And we split them in short-term readmissions, so readmissions within 30 days after hospital discharge, intermediate-term readmissions that occurred within 31 days after discharge and 6 months after discharge, and the long-term readmissions that occurred between 6 months and a year. The second question we wanted to address is what was the effect of certain subgroups. We wanted to focus on, does it really matter? Does the intervention intensity matters? Is there differences between age groups, and are there differences with regard to transitional care if you focus on specific diagnosis groups? And the third question was, are there specific intervention components provided in transitional care that were associated with a reduction of readmission rates? We defined transitional care as defined by Mary Naylor. So the goal of the interventions that we included is to ensure safe transitions between hospital and home and to minimize hospital readmissions. The duration of the interventions we included was time limited. So that means that they had to of a duration shorter than a year, because otherwise it was considered as case management or disease management. We targeted chronically ill older adults, and the timing of the intervention had to be during hospitalization and at least until 30 days after discharge. So if only a telephone follow-up after discharge was included, that was not considered transitional care. If we focus on the effects of 30-day readmissions of transitional care, there were 10 out of 26 studies that actually measured the effect on 30-day readmission rates, and these included 3,200 patients. What we saw is that there was a reduction with regard to readmissions in the transitional care group. However, it wasn't statistically significant on the 30-day readmission rates. And we also observed that the number needed to treat was 33. So that means that 33 patients have to be offered transitional care in order to prevent one readmission. The second question was, were there any differences with regard to subgroups? And we focused on high-intensity age and diagnosis. What we observed is actually only the high-intensity interventions, so a comprehensive discharge bundle with a lot of things that were conducted were associated with a reduction in readmission rates. There was a 41% reduction in readmissions in people receiving high-intensity transitional care interventions, and the number needed to treat then lowered to 20. If we focus on age groups, there wasn't a difference with regard to age groups on the short term, but on the intermediate and long term, we saw that transitional care was beneficial for older adults. The third question was then, what were the effective intervention components that were associated with a reduction in readmissions? And there were three components that reduced readmission rates. There was nurse care coordination, a home visit within 3 days after hospital discharge, and communication between the hospital and primary care provider. So if you look at the policy implications, and we also address that in the discussion section of the article, if you focus on the current procedural terminology that is currently put in place in the United States, which I think is a really good step forward. I think the US is one of the very few countries that really put in place a reimbursement for this transitional care. The way it's set up now, it might not be effective to reduce 30-day readmission. And the major issue is that the home visits, we found out that the home visits should actually occur within 3 days. And it's mainly because, like, most of the readmissions occur within the first week after hospital discharge. Half of the readmissions occur within the first week, and then the other half occur within the next 3 weeks. And if you focus on the Affordable Care Act and then Section 3026, where hospitals can, or organization can experiment with transitional care, what you can see is that it's still formulated rather broadly. So that means that there is some recommendations for these transitional care programs, but I think based on what we've shown is that at least we have now some evidence-based components that should be included in the transitional care protocol. And Leslie, there's also some steps to take to further advance transitional care. What we observed is that there were very few randomized clinical trials, I think actually 3 or 4, that really address cost effectiveness of the transitional care trial or the transitional care intervention. The second thing is that we included all-cause readmissions like most of the studies did, but there's really a big need to find a method to really identify the preventability of a readmission, because that is the only part that that the transitional care intervention will really be effective on. And then I think engaging patient and strengthening the role of patients is of importance. We didn't see much articles that really engage patients in the design of the trials, but also like empower patients to take their role in this transitional care. That would be also important. And it would request training of the healthcare professionals. And the last point I wanted to address is the role of the primary care system. If you focus on the National Health Service in the UK, what we observed is that, like, the more primary care beds you have available, the lower the readmission rate. So it would be of great interest to see more system-wide interventions focused on primary care systems. And at last, I wanted to acknowledge my colleagues, especially Kim Verhaag. She was the first author of the paper and did a tremendous amount of work on it. Thank you.
Good morning. I'm very pleased to be here today to present the CliffsNotes version of our paper, a comparison of how 4 countries use health information technology to support care for people with chronic conditions. Let me motivate the paper using some data from the US. What you can see on the left is a graph showing the rising incidence of diabetes, though this data could be true for almost any chronic condition and really could be true across a range of countries. As we all know, what this is doing is driving up healthcare costs and placing an increasing burden on countries at a time when they're already struggling financially. So recognition that the healthcare systems are not designed to deliver chronic care effectively well, and a lot of systems are really built on an acute care model and are struggling to make the transition to effective chronic care. And so at the root of this is really a lack of tools and ability to manage information and to facilitate information flow. What this means is that when information is stored in paper records, and even when it's electronic but can't be moved effectively, you can't do basic key tasks like care coordination, engaging patients in self-management, working on population health issues. I think none of us in this room would want to be given a stack of paper charts and be told, tell me what the diabetes incidence is among this group of patients, right? It's just it's not tenable. So in response, what countries have done is invested in e-health strategies, developing e-health strategies for the nation. And what we've seen is an increase in adoption of electronic health records and other types of health information and communication technologies. And so the graph on the right, again, is US data showing electronic health record adoption among physicians. Again, this data could have come from many countries, though the timeline may have been shifted a little earlier. The US has done some quick catching up in the past few years in this domain. However, these tools are not silver bullets. In and of themselves, they don't deliver care or alter the course of chronic diseases. And so the common challenge facing countries is now that they've made these substantial investments in health information and communication technologies, how do those translate to better chronic care? And so that is really where the opportunity for cross-country learning comes in. So what we did to help jumpstart this cross-country learning in the domain of translating health ICT adoption into better chronic care is to profile 4 countries. We looked at Australia, Canada, Denmark, and the US. The goal was to pick countries that were quite different in terms of their health structure of their healthcare system, how long they'd been working on health information and communication technology adoption, and what their focus and emphasis areas were in terms of the types of tools they're investing in. And then for each of these countries, we looked specifically at the types of technologies and their approach. So we looked at electronic health record adoption and the extent to which clinical decision support was included. We looked at what's often called health information exchange, the electronic sharing or movement of data to enable information to follow patients across settings of care. We looked at telehealth, something we've heard a bunch about today, and telehealth remote monitoring interventions. And then we looked at patient-facing technologies, tools to help engage patients in their care. So for each country, we looked at those 4 dimensions to understand what their approach was, and then tried to draw common lessons learned across the 4 countries. So in my time today, I'm not going to be able to tell you about each of the countries, but what I'm going to focus on is the 4 themes that emerged from going through that exercise. So the first theme is national vision and local innovation. So while countries have national e-health strategies, the implementation of those strategies and the innovation is largely taking place on the regional and local level. The challenge that creates is how do you bring successful pilots to scale? So an example that we refer to in the paper comes from Kimberley, Australia, where the Aboriginal population had a high incidence of chronic illness and a lot of challenges with access to the system, a lot of unpredictability in terms of where they would show up for care. And so in that region, what they developed was called a care planning platform that could be accessed by caregivers across the region to coordinate care. That in turn informed what's called the primary care sidebar in the national patient-controlled electronic health record that they're implementing across Australia. But the question is the success that they saw in the Kimberley region going to be replicated, right? The tool is there, but is everything else in place to make that tool effective in bringing care teams together to manage chronic care? So that's really an example of this challenge of bringing local innovation to a national scale. The second theme we call to exchange or to share. The challenge of health information exchange is everywhere across these countries. If any country tells you that they are figured out how to get information to follow patients between delivery settings, please be skeptical because it's perhaps the largest challenge facing these countries. And what we're seeing is 2 different approaches that are being taken. In Denmark and the US, started out with more of an approach of point-to-point sharing, making sure that if I know that a patient's going to a specialist, that I send the information along with them. Canada and Australia have taken more of an approach of building a longitudinal patient record that pulls data from locally held electronic medical record systems to try to create a sort of common repository that anyone who's treating that patient can access. But increasingly, both of those countries are trying to experiment with the other model. And so it's really an area in which we're really trying to see what's going to work and what combination of this point-to-point or shared repository model is going to work. But increasingly, what we're struggling with is not just sort of how do you get the information accessible, but how do you make sure that the clinical decision maker is using that information when it is available. And that's a very different set of challenges related to workflow, using information from other settings. And so what we're seeing is a movement into sort of that next phase of challenges. Now that the information is starting to move and be available, how do we make sure that it's used? The third theme is really opportunities for telehealth growth. We saw a lot of really promising pilots in all the countries that we looked at. Sometimes they had different flavors, so integrated home monitoring, nurse-mediated remote monitoring. The U.S. Veterans Administration has done a lot with telehealth interventions around mental health. But the challenge is that these pilots really tend to be isolated from core health ICT strategies and infrastructure. So there's a lot of rich data that's being captured in these pilots and interventions, but they're not integrated with electronic health records and sort of other health ICT strategies. So the opportunity here is really to think about a more comprehensive health ICT solution that draws on telehealth pilots and brings them much more into the fold as opposed to keeping them as standalone pilots. The fourth and final theme relates to moving from patient access to engagement. All the countries have made substantial progress in making sure that patients have access to their information, that you can log into a portal or log into this patient-controlled electronic health record in Australia and see the information about you that's available. But what we haven't really seen is starting to take the next step and engage patients in using that information. Not just that I can see my lab test result, but what do I do because of it? And that's, again, I think the next frontier that countries are thinking about is how to make sure that this information leads to sort of behavior change and more understanding about how to engage in chronic care. So those are the four themes. I think the point is that all countries are facing these similar challenges despite different delivery systems, despite different investments in health ICT. And so there's really an opportunity for cross-country learning. And we hope that these four themes may serve as the beginning to bring countries together to figure out how to address them. Thank you.
I'm going to quickly ask a couple of questions so that we have a little time for the audience. Bianca, your most robust finding was about home visits within a couple of days, and it reminds me that in the U.S., when we moved in Medicare from a per diem to a DRG payment method, we saw a very rapid reduction in average length of stay because the financial incentives shifted. It makes me wonder about the relationship between readmission and the underlying payment method for the admission in the first place. When you're looking globally, what kind of variability do you see on the underlying payment that might then have an effect on the on how a transitional care plan would affect readmissions?
Yeah, thank you. We focus on also on the healthcare system. So does it really matter in what kind of healthcare system the intervention is provided? We didn't see any differences between the healthcare systems. I think it's also because we included studies that were mostly conducted before 2011, where the readmission penalties were not introduced yet. If you focus on the readmission penalties, actually, these are only like apparent in the United States and in the UK. In the other healthcare systems, there are no penalties for readmissions. And actually, yeah, most of the articles didn't really report about their healthcare system, so it was really difficult to find out like what kind of payment system they have. So we didn't find any differences between healthcare systems, but it wasn't really. Yeah, articles didn't really report that. Yeah.
Thank you. Julia, I'm interested in the relationship between theme 2 and theme 4. When you think about the choice between patient-to-patient versus shared information flow, I think of that largely as a payer or provider-driven choice. Theme 4 was the importance of engaging patients. How do we make sure that the answer or the path forward on theme 2 is supportive of your fourth theme of patient engagement?
Yeah, it's a great question. I think what we're seeing now is sort of everyone's trying to do it, and that's not clear that it's the effective strategy because patients are getting very mixed messages, from payers, access this source of data for these purposes, from providers, access different source of data for different purposes. So, I mean, I think they need to be brought together. I think when we looked across the countries, there was as opposed to the US, other countries had less direct payer engagement in these care management activities. It tended to be more provider-led and providers that had access to the same comprehensive source of data. And so I think that that's probably the way that we need to move, mostly so that we're sure that everyone is looking at the same information and making a single care plan for the patients, because I think if not, it has the potential for worse outcomes.
Great, thank you. Questions from those of you in the room? Let's bring a microphone up here, and then we'll get the next one back there.
Thank you. I'm Bev Johnson from the Institute for Patient and Family-Centered Care. I was interested in your paper on transitions and reducing readmissions. You talked about strengthening the role of the patient, the older patient. I never heard the word family in any of that work. I think if we're going to care effectively for older people, we need a broad definition of family and much more proactive outreach to families, and that would also include using technology to involve families who may not be in the same community. Was there any thought of that in your paper at all?
Yeah. Actually, we looked at also the engagement of families, but also like was the informal caregiver or the family included in the intervention. We have some information about it, but and I think you're absolutely right that it's not only about the patient, and especially in older persons, it's about the family that you should include. So yeah, there's some words about it in the paper, but and I think you're absolutely right that we should do it much more than we do now. Yeah.
We had a question in the back. Can someone get a microphone to her? No.
Hello, I'm Abiola Fashion. I'm an emergency physician at the University of Pennsylvania, and I'm also doing a master's in health policy research. My question is to Dr. Buurman. I'm interested in these transitions of care, especially in the emergency setting, and I think frequently we're sort of not really the area that people are thinking about, even though the majority of admissions, at least here in the US, come through the emergency. So we see a lot of the bounce backs. And a lot of times, the problem is this transition of care because we're frequently admitting people because we have no other alternative. I'm wondering if, in your paper or in the research that you are doing, you found any initiatives or any ideas about how we could implement these sort of care strategies into the emergency setting, given our constraints with a very limited time with the patient. We don't have 10, 15 days to work out social work and all of that. How do we do this there? Because I feel like sometimes when we're doing it from the inpatient setting, it's already sort of downstream. You've already lost, your opportunity because they've already come to the ER and are already admitted from there. If you have any thoughts on that.
Like most of the articles that the RCTs that we included, it didn't involve like emergency care, but it was a lot of acute admissions. So that was people that coming through emergency care and then were admitted to the hospital. I think it's already extremely difficult to implement these transitional care interventions within the hospital setting and in the discharge home. Yeah, I think and maybe my colleague can also say something about it, like especially IT-based things could help to transfer information transparently, because I think having the right information is really crucial. I think asking about the medication, and if the medication is clear in the emergency department, is one of the major things, because also after discharge, and especially what we observe is that the home visit within 3 days after hospital discharge is really crucial or really effective to reduce the readmissions. I think this would also count for emergency care, because I think oftentimes changes are made to medications. So I think maybe if you want to do a small thing within the emergency department, targeting the medication would be of vital importance.
Additional questions? I'm going to throw out one just since we have a minute. This is a tough one, but I'm trying to pull in a little bit from earlier this morning. Both of you talk about draw your data from around the world. And we have research evidence, and we have themes of issues that various nations are confronting. Did you observe any efforts to promote cross-national learning? When you looked at the studies, was there any evidence that anyone is trying to either think of interventions or data collection that transcends national boundaries, or are we still very much at the one country at a time when it comes to both of these kinds of work, particularly given that both of you focus on chronic care, and there's certainly a global understanding of the growing role of chronic conditions as a driver of poor health? Anything?
Sure. Yes. So no, absolutely. I think in the area that I spoke to, there have been efforts by the WHO, the European Commission, OECD, but we're actually starting from a very basic level. The OECD is trying to get countries even to measure ICT adoption in a consistent way, so that we know who has which types of technologies. It sounds simple, but it's actually a very complicated question, because you say, to a physician, do you have an electronic health record? Right? Physicians in different countries are going to answer that question very differently. So we're now just at the beginning of being able to collect systematic data to say what infrastructure is there, and then I think we'll be able to start to tie that to chronic care outcomes, and then I think we'll really be able to say which countries are really ahead and which domains are not. Right now, it's largely been anecdotal.
Yeah, I would say the same thing. If you look at on the national level, I think it's acknowledged that it's a huge problem. But if you focus on the studies we included, there isn't any cross-country comparisons or cross-country. Relevant. Yeah, there isn't any cross-country comparisons between the countries. Yeah, between the studies. Yeah.
Okay, thank you very much. We'll move to our final panel. Thank you for coming up. We are going to wrap up with a panel that will discuss papers that all address the issue of innovation and improvement around the globe in healthcare. You will hear from Greg Parston, the Executive Advisor to Lord Darzi at Imperial College of London's Institute of Global Health Innovation. He is responsible for that institute's global research on diffusion of healthcare and innovation, and his paper is on that topic. He's also responsible for the WISH Global Summit on healthcare innovation. Dr. Alexander Knuth is the medical director of the National Center for Cancer Care and Research and chairman of Cancer Services at Hamad Medical Corporation in Doha, Qatar, where he has been since September 2013. You'll hear from Felicia Marie Knaul, an associate professor at the Harvard Medical School and director of the Harvard Global Equity Initiative, where she is director of the Global Task Force on Expanded Access to Cancer Care and Control, an initiative that she helped to found in 2009. And finally, Susan Edgman-Levitan is the executive director of the John Steckley Center for Primary Care Innovation at the Mass General Hospital, and before that, she was the founding president of the Picker Institute. Please, let's begin with Greg.
Thank you very much, Alan. Both the National Institutes of Health and the Royal Society of Medicine report that it takes on average 17 years for many healthcare innovations to translate into clinical practice. Google it. If 17 years is the answer, you'll find that the question is, how long does it take to translate new findings into clinical practice? I think we would all agree that that's simply too long. To be fair, some of that time is understandable. Clinical trials, development of databases, these take time. But much of the delay is not understandable. The progress from bench to bedside needs acceleration. And with that time lag as our focus, in 2013, we launched a continuing program of research at the called the Global Diffusion of Healthcare Innovation, GDHI, to try to develop a better understanding of how to fast-track the adoption of innovation. The study, supported by the Qatar Foundation and presented at WISH in that year, focused on 8 countries, all with significantly different health systems, and all of them in developing or emerging economies. The study involved over 2,200 healthcare and health industry professionals in quantitative surveys, as well as over 100 healthcare experts being interviewed personally. In a preliminary phase of our work, conducted at Imperial College's Institute of Global Health Innovation, we had first established a framework of diffusion that could be used in the GDHI survey through interviews with about 25 leaders of health systems around the world. The framework comprises 3 sets of influences that may aid rapid diffusion of innovation. First are the relatively fixed system-wide or national macro characteristics. These can change, but only slowly and over time. They include factors such as GDP, investment in medical education, spending on R&D, regulatory and patent activities. All of these have been fairly well studied over many years by OECD and by others exploring the field of innovation generally. But second is a set of regional and institutional agencies and agents that facilitate and support innovation and the uptake of innovation. These enablers, as we call them, which include factors such as incentives and rewards, ITC infrastructure, and enforced clinical protocol, can be initiated or modified comparatively quickly. We found that there has been some, but less study of these over the years. The third factor, which Ara had mentioned earlier, is what we called cultural dynamics. These are behaviors, beliefs, and practices of those working at the front line of healthcare delivery. They include engagement of stakeholders, like patients and clinicians, and management choices, like creating space, which means both time and money, for learning. Some experts, like Don Berwick from IHI, have made knowledgeable assertions about the importance of these cultural factors, but our study discovered little rigorous research on frontline cultural dynamics. So, in our global study, GDHI focused on enablers and cultural dynamics in the 8 countries, exploring their importance and their prevalence for the enablers at national and systems level, and in the case of cultural dynamics, at the point of care. What we found, there are many interesting correlations and differences and commonalities. These are all reported in our article in Health Affairs. As all personal surveys are, our findings are based on self-reporting. And so our current study, we're trying to observationally give evidence to all of these findings. But let me report here on 2 of the most significant. First, while different countries and health systems use different sets of enablers to encourage the spread of healthcare innovation, incentives are very important in the United States, for example, but they're not so important in all of the other countries we studied. There is a significant gap nearly everywhere between the importance that national experts place on these enablers and their prevalence in the systems. This gap needs closing through national and system-led action if diffusion is to be sped up. There is a further significant correlation, moreover, between prevalence of enablers as a whole and the prevalence of cultural dynamics as a whole. We do not know yet what is driving the other. What we do know is that if enablers are not so prevalent in the system, as is the case in, here for example, Spain and South Africa, behaviors that foster innovation at the front line are not so prevalent either. Where prevalence is high in one set, so it is in the other. Second, of the 7 cultural dynamics that we studied, 3, identifying and supporting clinical champions and leaders, harnessing the efforts of patients, and addressing the concerns of healthcare professionals, are commonly most prevalent among all countries studied. Indeed, in the most developed economies studied, Australia, England, Spain, and the US, these are the top 3 behaviors and practices at the front line. As important, however, is the significant difference between the prevalence of these top 3 and 3 other cultural dynamics: adapting innovation to local circumstances, creating time and space for learning, and delayering, or getting rid of old ways of working, which are commonly much less prevalent, although we do see some difference in 3 of the emerging economies. Now, related to this, let me make a final personal observation about the front line. Having worked on organizational change in healthcare around the world for over 30 years, I was surprised to see that the dynamics that were most prevalent in the countries we studied were about people: clinical champions, the public, patients, staff, and building relationships with them. We know from other research that scientists, clinical professionals among them, do not generally score highest in the emotional quotient stakes. and yet it is here where they are excelling in the fusion of innovation. Where they don't do so well is in the managerial, transactional set of behaviors, making time and space for learning, adapting innovation, and most important, delayering. Why is that? Is it because these are tougher things to do, involving challenging the practices of colleagues, questioning clinicians' inherent and highly valued reliance on doubt, and short-termist financial planning of healthcare institutions? I don't know. We're now in the next phase of GDHI, examining in-depth case studies in another 8 countries to try to learn the answer. But the tough question, why aren't we doing more of the tough stuff, bears thinking about by all of us. For if we can learn more and act on that, we may speed up the time it takes to get from bench to bedside. Thank you.
It's a pleasure to be here. I'm talking about our paper, Challenges in Adapting International Best Practice in Cancer Prevention, Care and Research for Qatar. And I'm happy that our paper was accepted in this issue of Health Affairs. Now, Qatar is a small country, and Qatar is a high-income country. It is probably one of the richest countries in the world by per capita gross domestic product. Qatar has a rapidly growing population with an influx of 23,000 new inhabitants per month. In a population currently over 2 million, about 20% are ethnic Qataris. The population is young, with less than 8% over 50 years of age and less than 1% 65 years of age and older. The expatriate workforce is mostly young men. Public health care is essentially free of charge in Qatar. It is provided by a public primary health care corporation and by Hamad Medical Corporation, which provides secondary and tertiary care. The National Center for Cancer Care and Research, of which I am the medical director, sits within Hamad Medical Corporation. Less than 10% of healthcare in Qatar is provided by the private sector. Qatar is the first country in the Gulf Cooperation Council to develop and implement a cancer control program as recommended by the World Health Organization. And with this national cancer strategy published and launched in 2011, Qatar made a major leap forward, adapting international best practices in prevention, cancer prevention, care, and research. The results within a 3-year time span have been remarkable, achieving accredited world-class standards in many fields and areas of cancer care. Achievements like that are not only bought by wealth. It is rather the concerted effort of highly committed individuals, teams, and organizations who orchestrate this remarkable progress. Qatari expectations in healthcare, and in particular in cancer care, are high. Rapid service and top quality are demanded. However, each year, hundreds of Qatari patients seek medical help abroad, also for cancer care. With the implementation of the National Cancer Strategy, this trend is reversing as trust and respect is growing for the achievements back home in a strive to develop world-class cancer care in Qatar. What are the specific ingredients that brought about this change in perception and recognition of quality of care as benchmarked against international best practice at leading cancer centers in the world? A thorough survey was undertaken before the implementation of the National Cancer Strategy, and it identified areas in need of rapid improvement. I've listed them here on this slide: access to treatment and waiting times, multidisciplinary teams to discuss all new cancer patients, subspecialization in cancer diagnosis and treatment, implementation of basic and translational cancer research and early access to new treatment options, possibly in the context of clinical trials, cancer prevention and screening, and cancer awareness and myth refutation. The goals of rapid access to treatment are setting highest standards in Qatar. For a patient with a suspected diagnosis of cancer, 92% have been referred within 48 hours by July this year, 2014. Primary health care will contact the cancer center through a direct and dedicated telephone line. In most cases, that is about 87%, the referral was communicated within 1 hour. From the first appointment to reaching a definitive diagnosis within 14 days, the success rate was only around 50% with a clear upward trend. And from diagnosis to onset of treatment, 97% of patients started treatment within 14 days. The role of patient pathway coordinators, that is qualified nurses, who smoothen the complex pathway from referral through tests to diagnosis, was established and has greatly improved the communication between specialist patients and care teams. And here is listed the number of patient pathway coordinators that were hired over the past years. These goals and achievements are very ambitious and exceed by far what I have experienced in European countries, and we are proud of this achievement. This not only reflects the commitment of the clinical teams, but also the impact of the introduction of multidisciplinary teams for the management of our cancer patients. As every new patient with a suspected or confirmed diagnosis of cancer will be seen in one of the, by now, 14 MDTs, all MDTs are subject to an international formal peer review, and so far 4 have passed this review with very good marks and helpful suggestions for further development. The benchmarking against top international cancer centers helps us defining areas of improvement. Also, it reassures us about the quality of management of our patients diagnosed with cancer. This includes an assessment and evaluation of the documented patient experience during their treatment in our cancer center. As we are building an academic health system in Qatar in close collaboration with our academic partners like Qatar University, Weil Cornell Medical College and others, we are implementing basic translation and clinical cancer research. This is a major priority as outlined in the National Cancer Strategy of 2011 and in the National Cancer Research Strategy that followed in 2012. A translational research facility with 40,000 square meters of research space is under construction, and an ad interim translational research institute has opened in the beginning of the year. A major research focus is on cancer genomics, cancer immunology, and cancer immunotherapy with regional and international collaborations and study groups. For the translational part of this project, a clinical trials unit is under construction with the specialized personnel under recruitment. Links to international trials consortia are established or in negotiation. Oops. Cancer is now the 3rd leading cause of death in Qatar after heart disease and diabetes. Within the next 15 years, the cancer incidence will sharply rise, probably triple, due to a growing and aging population, lifestyle risks, environmental exposure to carcinogens, to name just a few. A major effort has been to support cancer awareness and prevention measures. This starts with education in schools and public awareness programs through the media and through religious channels. Screening programs are being established for the major cancers like breast cancer, colorectal cancer, and cervical cancer. There's a community outreach program with home care services in preparation, rehabilitation facilities, and a survivorship program to show role models after the successful treatment of cancer. The most important cancer prevention measure, though, has recently started by a strict ban on smoking in public areas such as malls, government buildings, and hospitals, including our hospital. I joined the team a year ago, and I'm impressed by the momentum surrounding the strategy, and I really enjoy to contribute to this grand move forward for cancer services in Qatar. Thank you.
I'm thrilled to be able to join you, and I just first want to thank Health Affairs, and particularly Lord Darzi, and also co-authors, beginning with Mark Steedman and our dear friend Sir Tom Hughes-Hallett, for all of the work that went into undertaking this paper and the work that was undertaken with WISH and with Qatar. We deeply thank as part of the Dying Healed presentation that was undertaken about 1 year ago and led to this paper. I realize that one of the points that came up just now is that we need an emotional quotient. And so I do want to start with that. I come to this honestly as a patient who lives cancer. And one of the points that most drives me in doing this work is that I can't imagine waking up to a mastectomy without pain medication. It is bad enough, believe me, to wake up to one with pain medication. Yet that's the reality throughout the world. And I have to say, though, that when we began our advocacy work in Mexico, my husband and I, Julio Frank, and formed this small NGO, Tómatelo a Pecho, we really did not take into account the need for pain control and palliative care, the need for end-of-life care, and probably that reflected my own fear. And that fear really came to life when I visited this patient in a small secondary level hospital about 2.5 hours away from Jalisco, from Guadalajara, Jalisco, Mexico. We thought we were going to get her treatment for her cancer, and we found an obese woman dying from brain metastases. And there was no way to provide any kind of care near to where she was. And the first thing that we were told was, send her to Guadalajara. And what brought tears to her child's eyes were not that her mother was dying, was that she had no idea how to move her mother and get her on a bus for 8 or 10 hours to that level of health where she could get some care for end of life. We struggled to try to provide what was required in a system that is supposed to offer universal health coverage. And that brought many lessons. And so here I go from the anecdote to the evidence, because I think what we believe and the inspiration behind these papers is that we need evidence-based advocacy, but also advocacy-inspired evidence when we do the sort of work that we're doing in this particular case. The map that you see before you is part of the work that was done by the Global Task Force on Cancer. What these maps do is, instead of mapping geography, they map access. And what you can see is a grossly deformed map, a blowing up of the United States and Canada. This is access to morphine for patients who die from HIV, AIDS, or cancer in pain. Treat the pain data, much of which is reflected in our paper. Mexico is that 3,600 milligrams per capita. The US and Canada, around 344,000. The 10% poorest population in the world have virtually no access, about 200 milligrams per capita per death in pain. And the richest part of the world, almost 100,000. I have seen in my work for 25 years as an economist, many inequities and a lot of variance measures. I have never seen anything as unequally distributed as we see in this map and the data that we presented in the paper. Now, you could say that things are getting better. It is true. This is Latin America versus the United States and Canada in trends in opiate consumption over about 40 years. And you can say that things are getting better, but bear in mind you are seeing a logarithmic scale. There's no way that I could put all of this onto one PowerPoint slide. We would be projecting over on this wall the United States and Canada. So the divide is, in fact, widening. Now, all of this is happening in the context of a profound and rapid epidemiologic transition. We've heard a little bit about this earlier this morning. The world is seeing an increasing burden of DALYs, disability-adjusted life years, death, and also disease and living with disease associated with non-communicable diseases like cancer. And these tend to require pain control and palliative care. Yet, as we say in the paper, we have a serious deficiency in terms of what's available in health systems. Less than 10% of the world's health systems have integrated access to pain control and palliative care or end-of-life care, and the vast majority actually have almost no access. At the same time, there's a message in this paper that's very important. There are innovations. There are a series of countries, low-income countries around the world, that are responding in innovative ways. I'll briefly say a few minutes about Mexico when we get there. But in the meantime, what are these innovations and where do they have to come from? The obstacles are discussed in the paper, and there are a number of them. They relate to the advocacy, the fear of death I told you, but also to the lack of human resources, the lack of stewardship, the lack of delivery models, and the lack of access to pain medications that are plaguing health systems around the world. Now, all of this, though, is happening in the wave, the global wave towards universal health coverage. And as WHO defines universal health coverage, that does, in fact, include palliative care. Yet, for some reason that I'm just beginning to try to understand, pain control and palliative care is almost universally ignored in universal health coverage. Now, how do we remedy some of this with a systemic approach? I won't go in detail, but I will say that we're working on the idea of effective universal health coverage. When you're talking about chronic diseases, that means looking across the continuum of disease, but also across all four of the health system functions: stewardship, financing, delivery, and human resources and evidence building. It's a much more complex model. Some of the more innovative solutions, I believe, in the health reform scene are about diagonal strategies that think both vertically and horizontally. This is an idea put forward by Julio Frank and Jaime Sepulveda. But it turns out that pain control and palliative care are sort of the sine qua non example of a good diagonal strategy. There are positive externalities. If you reduce barriers to access to pain control and palliative care for cancer, you're actually doing it for all diseases, and you're generating a systemic platform of support for initiatives like surgical interventions. You can also think about diagonalizing interventions by integrating within health system reforms, within Social Security, and within national health insurance platforms. These, we believe, are the way to think forward, and what you end up with are systems in which the costs are actually spread over a much larger number of benefits, so that you get a much lower cost-benefit ratio. What's going on in Mexico, very briefly, because the paper does discuss several initiatives, and we're doing a lot of this in the Mexican context. We have a strong legislative platform, which is rather unusual, a reform to the national health law that provides for palliative care. Yet the vast majority, again, of our deaths from HIV or cancer, the vast majority continue to happen in pain. And this is in the context of a country, and I was one who helped to make that happen in some small way, but also wrote about it in The Lancet. We talk about universal health coverage. When we look, as we've done across the health system, applying that view where you analyze all the way through the different functions of the system, we find that we're totally deficient in terms of palliative care and access to pain control. And that forced us to ask the question, can you actually have universal health coverage if you don't offer the basics, the very minimal, which is pain control and palliative care? The response, and I'm very pleased to share, is that the government, working with civil society and academia and others, and in large part pushed forward by a report that will soon come out with Human Rights Watch, which shows the importance of advocacy, is putting together its first national action plan, fully integrated with civil society, with government, and across the spectrum of interventions around pain control and palliative care. And we're leading quite a bit of that work from the Mexican Health Foundation. In sum, I'm very much hoping that all of these initiatives from the countries, the innovations in health reform, will help with some new work that we're going to be doing very soon and announcing very soon with The Lancet to look at global answers and national strategies integrated within health system reform to be able to satisfy what we believe is one of these most basic of needs, access to pain control, end-of-life care, and palliative care. So thank you all very much, and thank you particularly, Lord Darzi, for all of your support in making this happen.
Good morning, and can I get my slides up? Here? just Okay, great. So I also want to thank Lord Darzi and the Qatar Foundation, and also my co-authors, some of whom are here today, for the pleasure of working with you and being able to do this work. What I'm going to be talking about today represents some of the work that we did as part of our paper on patient engagement for the WISH meeting last December. We talk about the 4 levels of engagement in the paper, but I thought it would be easiest to describe it if showing you the graph. So what our paper discusses is the importance of engaging patients and families and people, actually, in all the different levels of health care. So starting at the top in terms of public policy and governance, organizational governance of organizations and healthcare institutions, in the provision of direct care, which is really around the clinical relationship between patients, families, and their clinicians, and then finally at the level of community health and how we engage populations and people in activities that really focus on public health, much of which you've heard about already today. We put at the bottom of this pyramid the education of public and professionals, because we know that there are tremendous needs both on the side of patients and families in terms of how to be an educated consumer in this new world, as well as on the side of clinicians and people that lead healthcare systems and healthcare organizations in terms of the new skill sets that they need to be able to effectively partner with the people they are serving. And up the side of this pyramid, we talk about research because we have a lot of work to do on this front in terms of research about what kinds of partnership strategies are the most effective and have the strongest evidence behind them. And the other side of that, and I think this may be more relevant for the U.S. perhaps than some other countries, but how we actively involve patients and families in how we conduct our research. How are they involved in setting the aims? How are they involved in looking at the methods, looking at what outcomes we want to learn more about, the recruitment of patients, and other things that I think in this country PCORI is taking the lead on. So this is the framework that the paper talks about. And we focused on 4 studies in the paper, but I also included some examples from the research side of this and the education side. So in terms of community health, the ones that we chose were Big White Wall from the UK, which is a very effective online mental health service that healthcare systems can contract with. We're actually looking at doing that here in the U.S. that provides a series of services, both online therapy, cognitive behavioral therapy that people can do on their own, discussion in chat rooms and community support groups, as well as other tools. And it's been found to save about $650 per person enrolled in this in the NHS. We also talked about work that has been done in the UAE on genetic screening to help educate the population about issues that are very common there with thalassemia, G6PD problems, and sickle cell anemia. And through a lot of public education and engagement in a very culturally sensitive way, they've been able to promote genetic screening and reduce the risk of these illnesses by offering very low-cost genetic screening, which is a huge contrast in terms of the cost of some of these illnesses, which can be over $300,000 per person. We also talked about a program in India that was started by the WHO, and one of the things I think all of these programs include a lot of patient input into their design, which I think is critical. The WHO mother-baby checklist is a telecommunications through the use of cell phones to send messages to women after childbirth to alert them to things that they should be looking out for in their own symptoms and in the symptoms of their babies that are a signal that they should receive care immediately. And these have all been quite effective. The paper also focuses on Beth Israel Deaconess Medical Center in Boston because they won the Quest for Quality Award, which is sponsored by the American Hospital Association and McKesson. And as part of that, you have to demonstrate significant evidence convinced that patients and families have been involved in designing the way you deliver care and your quality and safety initiatives. And so they focused, there's a lot in the paper about their patient family advisory groups, as well as their use of Open Notes, which is a system that allows patients to actually see their clinical notes through their patient portal. On the policy front, we mentioned work in Massachusetts, where several years ago, statewide regulations were instituted that required all of our hospitals to create patient family advisory councils. And every year, every hospital has to report about the impact that these councils have on the way they're delivering care. Very quickly, I think many of you are familiar with PCORI. I'm actually involved in some PCORI grants, and it is amazing to me what a difference it makes to have patients and families engaged in a very deep and significant way in the research activities. And finally, on the education front, and here, again, I want to emphasize we need new education models for our clinicians as well as our patients, but one of my favorite education programs for patients is the National Breast Cancer Coalition program called Project LEAD that really educates women around the world about how to interpret scientific evidence and how to be really good advocates on the part of women with breast cancer. So what are some of the overarching lessons? We think that with the right support, people can not only help themselves, but also each other, greatly extending the reach of healthcare, which we cannot begin to do this alone through our caregivers and our health systems. And we also think that these methods are effective no matter where you are or what kind of health system or country you live in. So what are some of the new competencies that people need? The public needs to really learn a lot more about their bodies. We do everything we can to not educate people about healthcare, to not give them access to their own information. Clinicians have to be much more comfortable with these partnership relationships, and health systems have to take very, very seriously the engagement of patients and families in the redesign of care. And just one quick comment about Greg's talk. When you talk about delayering, as part of innovation, in my experience, patients are incredibly effective at helping us figure out what to get rid of and what to let go of in the ways that we've designed care. So I think I am out of time, and I want to make sure that we leave time for questions. But I think we argue that we need a new paradigm in healthcare that changes the conversation from what is the matter with you to what matters to you. And I will end not with a quote from Churchill, but a quote that I thought, is it appropriate to talk about Napoleon Bonaparte? But I love this quote. And so leaders are dealers in hope. And I hope that all of you will take this back home with you. Thank you.
We do have a little time for conversation here. I do want to begin, Greg, with following up on that body of work and then your closing sort of observation and try to get you to tease out a little more. The notion that creating the space and the delayering are lower on the list of what's happening in the places you examined, and then just tied into the closing comments we just heard. It does make me almost wonder if there are two different phenomena we're studying here, that thinking of getting rid of the old is not just a subset of innovation, but maybe it's an entirely separate phenomenon, and that's why you don't see it in sort of the top level thinking about innovation. I just wondered if stopping doing the old really is this, an element of innovation or a separate challenge from innovation.
I think it's a very important element of diffusion. And despite Ara's complimentary comments earlier, in the editing of our article, Health Affairs made us change the paleontology of innovation to the paleontological layering of innovation. So, but I'll continue to use my first term. We talked about the paleontology of innovation.
Since we have no editorial control over you at this point.
Absolutely, not here. I'm from Detroit. I don't do diplomacy. we know that there are a lot of things that get in the way of new innovations being picked up. And one of those things is that people have been doing this thing in the same way for many, many years. The current example being hotly debated in the UK is the continuing use of warfarin, when we have alternative anticoagulants which are safer. But we have whole warfarin regimes, we have whole industries of people whose jobs are based on the applications of warfarin, and yet we know that we've got something better. But we'll continue to do this, probably for 17 years, because that's how long it will take for us to do that. And so I think that it's not part of the innovation process, it's part of getting people to pick up the new things. And part of the problem there, I think, is that clinicians, and I think rightly and beneficially, are taught to doubt. And that's an important part of clinical practice. But that doubt can sometimes become self-protection. And that self-protection can sometimes stand in the way of effective and efficient care.
That's very helpful. Thank you. I noticed in both our second and third presentations, although they were on completely different topics, a unifying theme was a national strategy. And I wonder if the two of you would be willing to comment on sort of how that fits in our thinking about what it takes to take an idea that may exist either from guidance from the World Health Organization or something you observe in other countries and make it happen there. How critical is the role of having a defined and adopted national strategy, and what goes into making that happen, although obviously that would differ from place to place?
Well, a national strategy is not only a program, it's also a result of an intense survey before the strategy is written. And so the national strategy is actually reflecting where are the areas of need in a given country. And I think this was thoroughly done on the example of Qatar. And Qatar may be a very good example because it's a fairly small country and you have very good insight in all the different details that are involved in this. So I think the national strategy is always something that is tailored to a given country, and I think in that it has an individual value.
Do you want?
Two comments. I think one, just to say that national strategies can also help to push forward global strategies and vice versa. So I think there should be a symbiotic relationship. Now that said, our work in areas like access to pain control shouldn't wait for a national strategy. So in effect, the process of developing the national strategy, in a sense, is more important than actually publishing it, because that's when you learn. And I guess a part of me would like to say that I hope it's outdated by the time it's actually published, so that we're always pushing our way forward to new innovation.
I'm looking way down at the end. When discussing patient engagement, I was struck that most of the examples you gave us were single country examples, although you mentioned bringing the big white wall across from the UK to the US and Project LEAD, having a global profile. When I think about engaging people and patients, we have lots of ways to break down national boundaries at the patient level. So is there a similar internationalization or globalization of the kind of learning about how to engage patients, or are we still primarily doing this one country at a time?
No, I think that I think there's a lot of work going on internationally around engaging patients and families, either in helping to design new interventions or new ways of delivering care, or actually partnering with clinical teams in the ongoing process improvement activities. So I don't think that is unique to any particular country. I think another area where there seems to be sort of growing interest, which I think is critical and part of a very critical part of patient engagement and patient-centered care, is around shared decision-making and how we're beginning to engage patients both by providing them with the information they need to make informed decisions, but also really giving them the skills they need to do that in their interactions with their care teams. And that's happening, I think, much more broadly than people actually realize.
Great. We have time to engage you all in the room with questions for our presenters. Encourage you to join in the conversation. I'll even pause for another minute to continue to encourage you. I don't want to belabor it, but Well, then it's completely clear how we innovate, how we diffuse the innovations. I guess everyone wants to just get back to their office and make all of those things happen. Please join me in thanking these 4 terrific presenters for their information. As we wrap up, I just want to remind you again that the issue, have to use my visual cue here, that we released today would not have been possible without support from the Qatar Foundation, the World Innovation Summit for Health, the Hamad Medical Corporation and Imperial College of London, and the Commonwealth Fund. You see up on the screen some upcoming events in just 2 days. We're having a session that's related to the new Institute of Medicine GME report. And in October, our issue will focus on specialty pharmaceuticals, and the briefing associated with the October issue will occur on October 7th. Thank you all for joining us, and we look forward to your having a chance to look at and react to the articles in the September issue. Thank you.